I think Dr. Fonseca expressed the situation quite well. I can add a couple of things, though. Number one, as Dr. Rafael Fonseca pointed out, there are two ways to use MRD. One is for the regulatory reasons. That is, if we use it in our studies, perhaps we can get answers more quickly as to, for example, which drug A may be better than drug B because it achieves a deeper MRD more frequently. The other way to possibly use MRD is in an individual patient, that is to make clinical decisions. And this is still somewhat controversial in the world of myeloma. There are many of our colleagues who don't necessarily believe that it's time to use MRD to make these clinical decisions. I think Dr. Fonseca and I are in the group that feel that it is often helpful. It's not always helpful, but it is often quite helpful. And as Dr. Fonseca said, in our institution, our goal is also to achieve the deepest MRD possibly MRD negativity, 0 in a million. I'm going to show you a couple of slides of patients in a second to show you what I mean by that, and then we can open it up for questions. One of the things we haven't mentioned yet, though, is that in myeloma, unfortunately, the best way to measure MRD is with a bone marrow procedure, and many of you are familiar with bone marrow aspirate and biopsies. We are not yet at a point where we can use peripheral blood to make those decisions as we can, for example, in leukemia or lymphoma. So I think that's one of the major reasons why physicians and patients aren't using MRD as an endpoint or as a clinical decision-making point, because it's relatively hard to get it, and the patients are uncomfortable when they have the procedure. The day will come when we will be able to measure it in the peripheral blood, and I think when that day comes, everybody in myeloma will be using it, just as we use light chains or M-spikes. I'm going to share, can we share my slides again here and just show a couple of cases. This first one is a patient who happens to be also a friend of mine, who in 2011, after a transplant and a year of Revlimid, could not tolerate lenalidomide or Revlimid any longer because of a lot of side effects and low blood counts. And we decided to not treat him with maintenance. And you can see here, starting in 2014 in July, I started doing a bone marrow on him every July. He volunteers as a subject when I demonstrate to our new fellows how to do a bone marrow. So the first week in July, every year, we do a bone marrow on him. And every year he's had 0 in a million malignant cells. I think confirming, in my mind, maybe hopefully in all of yours, that this guy would have done just as well. He did just as well without therapy as he would have done with lenalidomide. And he would have had 8 or 9 or even 10 years now of toxicity. So there are patients taking lenalidomide now who probably don't need it as maintenance. There are other drugs being given as maintenance too, where we hope that someday we could figure out a way, perhaps using MRD, to know in which patients we can stop this maintenance therapy, because it's also costly, of course. This is another case, a similar case, in which I had a patient with high-risk disease, deletion 17p. We tend to give, after transplant, triplet therapy. This patient got Revlimid, Velcade, dexamethasone for many, many years, and then Revlimid for many years. And after 5 years, was just so tired of therapy, she began to ask if she couldn't finally stop therapy. And I had been measuring MRD in her, and you can see that early on, after the transplant, she had 18.8 million cells in a million, dropping to 4, and then 0. And over the next 5 years, 4 years in this slide, but still 5 years now, she had either 0 or 2 malignant cells in a million. And finally, in 2019, we stopped her maintenance, similar to the other patient. And she's done fine since then. I haven't put it on here, but she had another 0 just recently after being off of Revlimid for a year. So these are two instances where I think MRD is quite useful in the clinical management of patients. I'm going to show you one more slide, then we'll open up for discussion. This is, some patients present with renal failure and need dialysis. This is a gentleman who did. And after a number of years of therapy and on dialysis, and having a couple of MRD negative results, we convinced our kidney transplant doctors to do a related kidney transplant for him. And he's been off dialysis now for 4 years. remains in remission, and we've convinced the kidney transplanters that anyone who achieves an MRD 0 should be eligible for kidney transplantation. Could we discontinue my slides, please? So at this point, we can open it up for discussion. There are obviously many other areas we could be using MRD for clinical decision-making, and Dr. Fonseca and I would be very happy to discuss this with you.